Very good. I'll be short and quick.
Okay.
Yep. All right. So I kind of introduce myself. So I'm Wendy in my very final year, thank God, of my PhD. So I've been in part of the lung group at the ABI. So today I'll just be giving you a brief introduction on the computational modeling of the organ lung and its clinical applications in real life. So the overall purpose of our modeling is so that we can help clinicians and be used in real life and not just be restricted to a computer, right? So start off, I don't actually know how much background you guys have, so I'll be very simple and start with the simplest question: what is the lung? So what is the lung? It is the organ that helps you breathe, right? But more specifically, it is targeted so that we can obtain oxygen from the atmosphere that can be distributed throughout the body, so we can carry out respiration, and then we can eliminate metabolic byproduct that's not good for us, like carbon dioxide, from the lung, into the atmosphere. So this is the purpose of lung function. But this is actually a very difficult task to achieve. So the lung has a very complex structure. And here is a cast of the human lung. And you can see all the very complex structure of the branching lung. And the white is the complex branching of the airways. And the red bit is the artery that helps you to distribute blood flow. And then the blue bit is the vein. And all of them has a complex branching but interwoven structure that hopefully will arrive. Oh, how do I do this? That will arrive here, or bring you to bring the airflow and blood flow to a very close proximity to each other in a structure called the alveoli, where you can have the gas exchange, so where you can obtain the O2 and give rid of the CO2. And this unit, there's about 30,000 of them in the human lung. And the surface area, if you all combine them, given the small lung, is the size of a tennis court. So it's actually a very complex structure, and it's quite difficult to do. And with computational modeling, we hope to model all aspects of this lung, this complex process, from its structure to each component of its function. And why do we want to do that? We want to study it because it's interesting. The underlying basic physiology for normal function is interesting, and it's key to understanding of what we're really interested in, which is the disease case and how we can help. And our overall purpose is really to how we can use these models to improve patient care, right? How we can aid diagnostics and how we can improve therapy, right? And this is really the focus of our MedTech CORE. So for the process of gas exchange in the lung is similar for all of us, but actually my lung can be different from yours because individual differences and characteristics like your height, whether you're female or male, how old you are, your inherent tissue properties, all this can have big influences in how your lung actually function. So your lung will be different from the person that's standing next to you, right? And these regional and global function between different individuals is very important if we want to be able to capture the behavior of each individual in different circumstances, right? So, and if you have a disease, even if you have the same disease, your different extent of the disease and the different distributions throughout your lung means that it's presented differently in different individuals. And so even if you have the same therapy, because of these differences between the individuals, you might respond completely differently from the person next to you, right? But actually clinically, because the doctors are so busy, how we treat these disease is not really patient-based. It's really based on subject assessment by the treating clinician. So it's based on their past clinical experience, for example, and not so much on what we engineers like to focus on, which is the objective assessment, the hard data. So what the MedTech CORE wants is we want to use computational models that can predict personalized response and treatment. And overall, we can tailor this treatment for every single individual out there. And that can really help the clinicians in treating you better. Instead of basing on experience what might happen, try it or guess, we know we want to produce a personalized medicine, right? So, but to do this, we must first be able to capture the lung function. We have to be able to describe these complex processes and all the individual differences in between them in order to be able to predict individual response, right? So this is the general modeling framework used by the lung group. And to reach each of these components, these boxes actually represent a set of mathematical equations, a model in itself for each aspect of the lung function that we all want to capture. So it's actually forming a very complicated framework that we work from. And to build to get an accurate model, we want to build on the individual the individual characteristics of your models. So we base our models on CT data or imaging, and we build personal structural models of the lung, and then simulate this individual function and how your each different regulation of the system or framework to predict your lung function. And I will briefly walk through each of the steps of how we construct the modeling framework to predict your individual lung function. So, as I said, we base our models on real life data. So that's usually medical imaging. That's the raw data that we base our models on. And so on the left here is an example of the typical data, raw data that we deal with, which is usually a CT data. This is a CT data of a cross-section of a person's lung. And we can obtain a lot of individual personal patient-specific information from these that can help us to feed our models and do them well, right? So we do a lot of analysis, visualization analysis, using, for example, SingGUI and MATLAB to obtain a lot of information, right? Like the shape of your lung, the shape of your airways, your blood vessels, what tissue properties you have. So here is an example in MATLAB of a quad tree analysis of what we do. So you can see that this, in essence, will be able to give us a lot of information on the regional tissue properties of each individual. And as you know, me and you might be different in these tissue properties. And this is very important in capturing your individual functions, right? And based on these raw information, we can construct the lung model, which is, here is starting from these 3D visualization in SingGUI of the human lung. You can use these data clouds that can identify the boundary of the lung. So in essence, you get the different shape and volume and all the essential things of the lung. And we can see, and this is for, I think, the left lung. So using this, we can actually construct a volume mesh. Don't know if you guys have been through the tutorial finite element models of the lung shape, right? See, so this is the shape of the left lung, and it can have predictions of your tissue properties, and imagine if you have a disease, that can be quite important. And within this lung shape, you have your airways and your arteries and veins, the complex woven structure that we see before. We also want to capture this. And here is an example of in a pig, how we identify from this lung. Okay, so how we start from also the CT imaging of a pig, a 3D visualization. We can identify the arteries, the veins from them. So that's the data cloud that you see here. And we extend on those to formulate a full-grown tree of the whole entire pig lung. And that's all sitting within your lung tissue shape that's here. So you can imagine you already have different individualized personal geometry of your lung based on from the CT. Now you have a virtual one in the computer. So, and then based on this, we can simulate the blood flow that's running through it, right? By having the geometry, we want to simulate the function. So does anybody know what might be important in simulating the airflow into the lungs, maybe?
The body? Deformation?
Deformation, yes, the tissue properties that we saw, right? Body movement, anything else? individual characteristics like how fast I'm breathing at, how deep I'm breathing at, and all that, right? And the complex processes of what flow is directing towards where, right? So we have all these based on biophysically based equations, which we don't want to go into detail, or you can explain to me if you want. And by specifying the patient-specific properties, like your tissue compliance, that's your tissue properties, what posture you're sitting at, how deep you're breathing, how fast you're breathing at, we can actually simulate a moving lung, a moving breathing lung. And here is the actual lung that's breathing. So here you can see at every single, this is for one inspiration and expiration, so for one breath, you can see we can capture the expansion of the lung as it breathes, the pressure that's building through it at every single time step and every single location of the lung, at every single branching point. So we know exactly how much airflow or how much blood flow is going through each region of those lungs, and that is going to those gas exchange units where we can predict function, how much air you're going to get, how much carbon dioxide are you moving out. Similarly, for the blood side, you also have the complex structure of your arteries, your veins, and this is a ladder model representing the smaller arteries, the smaller, blood vessels that sits within the gas exchange unit. So it's really a multi-scale model from your larger airways, your larger blood vessels all the way to the smaller ones. Then by specifying also your posture, independent things like the posture, how much cardiac output, your pressure going from your heart into the lungs, you can get a prediction of how much blood flow that is going through each point in your artery, in your vein, and how much is actually given to the gas exchange surface, where is what we're really interested in. And you can see there's a lot of variability, even not just between individuals, but even within the lung itself. So here is a plot if you're sitting supine, so lying on your back. This is against gravitational height of your lung as you lie on your back, and this is the amount of flow that you get. You can see there's a gradient, there's even a difference in the blood flow that you get across the height of the lung, and not even that, or even across these units. These, if you consider the cross-sectional units, all of them are different. So there are huge variances even within the regions of the lung itself. And you can imagine how that will be very different between individuals in different terms of disease. And this is actually, this is a 3D functional visualization of the perfusion, the blood flow that goes through your lungs. And you can see that we can, with a computational model, that we can actually visualize this. And now that we know the amount of blood flow and airflow that is going to each of our 30,000 units, so each of these little tiny dot is a gas exchange unit, we can predict, we can use biophysics that describe the exact kinetics of gas exchange. So the mathematically based equations, we can actually predict function. So here is arterial, this is the partial pressure of oxygen in your arteries, which is a prediction of how much blood oxygenation that you're getting. So this is prediction of function for each and every single one of those units. And you can see there is quite a big range from 80 to 140 millimeters of mercury. And in addition of that, we have a feedback loop where you have regulation. So if there's slightly lower, if it's slightly lowered, your brain and your body can help to regulate to bring back up. And if it's too high, we want to depress it. And this is how we cope with normal everyday exercise. For example, if you're exercising or if you're slightly ill. And this forms really an entire modeling framework of how the lung functions normally. But of course, in disease, it's entirely different. And this whole entire system kind of breaks down the regulation. And this is actually what we're really interested in, right? So given this model framework, what can we actually do with it? What do we want to use it for, right? So I will provide two examples of how we can apply the system of models to really improve patient care, which is what we really want. So the first case, the first example I'll give is how we can use these models to help the diagnosis of a disease called acute pulmonary embolism, which is quite a common disease. So does anybody know anyone that had an embolism before or know what it is? Yeah? So an embolism is usually, it can be caused by blood clot or fat clot or maybe lymphatic tissues that have broken off and became dislodged into your artery vessel, your blood vessels. And when it travels and become blocked in your arteries in the lung, so like this is a contrast CT of somebody's artery, and all the red bits that you see are embolized. And so when it becomes blocked, it really affects your lung function. So imagine like you had a drain. If you had a blocked drain, then no blood flow or no flow will get past this blockage point, and you really have reduced blood flow. And without blood flow, you can't really carry out gas exchange because there's nothing that's going to absorb the oxygen and support you, right? So you have a lowered blood oxygenation, which is a reduced lung function. And well, giving back to our example of a blocked drain, if you have some blockage, you require higher pressure to try to push past this blockage point. So for the lung, the heart has to pump extra hard at higher pressure to go try to bring blood flow past this blockage point. And sometimes the pressure just gets too high, and you have right ventricular failure of the heart, which is quite a severe disease, right? So this is really quite significantly affects your lung function. Oh, and so here is a dual energy iodine map, which is a functional imaging of your lung function. So the red bits are where you have blood flow, and the completely dark bits are where an embolism has caused no blood flow. So you can see it can affect a lot of regions of the lung, and we really want to treat that. So a clot low score is a clinical indices that's really used to estimate the extent of obstruction of the blood flow in the lung because of an embolism. And we really want to use this because it can help you to classify your patients into higher risk groups who have higher blockages, higher scores, which you really want to treat. They're quite severe. And patients with a lower risk, which has lower scores and less obstruction, right? But the problem is that even however, this clinical indices actually doesn't really correlate well with clinical function. So a patient can actually have a higher score, but not much dysfunction. And some patients may have a reasonable score, but they have really severe right ventricular function. And what we want our model, the model framework that I just described, to do is to be able to explain why this happens and how can we improve this clinical score of the clot load score. And then so we'll return to our process of our modeling framework, where you have the CT data from these patients. And then so this is the 3D visualization of it from all different angles. You obtain your airways and blood vessel trees from the CT for these particular patients. And from that, remember our model of ventilation and perfusion, we can predict how much airflow and blood flow is going through for these patients. And more importantly, we are able to use the single visualization to identify exactly every single location, size, distribution of the emboli for this particular patient. And then so we can predict how these distribution of the emboli can affect this person's lung function. So we actually have a virtual patient corresponding exactly to the patient in the CT, and we can predict exactly how your lung is responding to this embolism. And what we actually find is that you can have the same clot load scores, but different function, different extent of the disease severity, right? So giving an example, if we have 2 patients and they all have the same clot scores of 45%, for this first subject, if they have a large and central emboli, meaning the emboli are quite big, and they're located nearer to the heart where you have really big vessels, these patients actually have very significant reduction or blockages of the blood flow. So that's the blue bits that you see here. And that means places where you have little blood flow, but there's airflow, so no gas exchange, is called a dead space. And so for this particular subject, there's a 27% increase in your dead space. And this is also shown here. So the blue is where you have ventilation and airflow, and red is where you have perfusion, the blood flow. So you see here, there is a significant portion of the lung where there is absolutely no blood flow. So you can see that there is a significant reduction in the amount of blood oxygen that you're able to get. And this is a reduced lung function. And for this particular subject, there is a predicted right ventricular dysfunction, so your heart is failing. But for another subject, subject 2, with the exact same clot load score as subject 1, but have a different distribution of the embolism. So if they have smaller sized embolisms that are more distributed throughout, so perhaps distributed throughout the periphery of the lung, there is actually less blockages, less dead space of only 20% compared to 27% for the first subject. And so that's you see here. And also you see here as well. So the region of the lung that has a blocked blood flow is much less. And what we actually see is there is no significant change in this particular person's blood oxygenation, and there is no right ventricular dysfunction. So you can see that even with the same clot load scores, these patients behave differently. And what our modeling is showing is that the visualization, so this is the visualization in single wheel function. So the visualization of the size and the location of your embolism for each individual patient is very important in predicting how severe these patients are at, so their dysfunction, and how it's very important in classifying the patients into higher or lower risk groups, which cannot be predicted by using a simple clinical indices of a clot load score. Right, so this is really the unique advantage of our visualization and our modeling framework that can help diagnose this patient accurately. So we won't, so maybe for this 2 patients, they might consider the clot load score is okay and they're not severe, but actually for subject 1, they really need treatment because it's a severe form of the disease. Yeah. And so, second example that I'll give stems from part of my PhD project, and it's really a pilot study of how our modeling framework can be used to aid understanding of therapy, of treatment of different patients, and how we can use a generalized one model to represent and predict a function of a whole group of patients. Right. So the example we're using here, as Nina has mentioned, is non-invasive ventilation in a particular form called nasal high flow, which you will hear about from Fisher and Paykel this Thursday, I think. So what is nasal high flow? Is this thing that you see here. So it's able to deliver heated, humidified air at very high concentrations, at a very high flow rate through the nasal prongs. So that's here. And it's really quite commonly used. Have you guys ever used one or know anybody? Seen it? This particular thing? No? Cool. You will this afternoon. No, tomorrow afternoon. This particular thing has been quite prevalently used, and it's very popular nowadays to be commonly used to people who have been under respiratory distress. They have difficulty breathing, and it's really shown that it can improve oxygenation, your blood oxygenation, and can reduce the stress you're at if you can't feel like you can't breathe. So it can really alleviate that stress. But the funny thing is, we don't actually know how it works. There are many studies that have hypothesized that perhaps one of the mechanisms used is it can work by delivering a higher concentration of oxygen. So if you receive a lot of oxygen support breathing in, it can improve your blood oxygenation. Some other people think that because there is a higher flow rate, so here is where you have the trachea and the major bronchi. This place have airflow but no blood flow, so it's a dead space. So by having this high blood flow, it can reduce the amount of dead space that's being wasted and that's not participating in gas exchange. So this may be one of the mechanisms and how it works. And another mechanism they hypothesize to work is people in respiratory distress or have reduced lung function may have regions of the lung, like you see here, when they have a region of the lung that's collapsed, so it's not working anymore. So you have reduced lung function. And maybe some people say that this particular high flow mechanism can open up this previously collapsed lung, and then that can improve lung function. But we actually don't know which one works. And we don't actually know which of these mechanisms works or how much it works by. So the clinicians don't actually know this. And how this therapy is used is by trial and error. We turn a knob to adjust the flow rate, adjust the input concentration, and predict, is the patient feeling better? If it's not, we turn another knob. So this is really a trial and error approach. And what we want the model to do is we want the model to be able to predict these patients' responses and see which one of these mechanisms actually work, how much it works, and which patients these mechanisms work. Right. So we have 20 patients that have undergone cardiac surgery, so we actually have real patient data. So for these 20 patients, they have undergone cardiac surgery, and we know that a portion of their lung are collapsed, so they actually require nasal high flow therapy. And so what we have the patient data is, initially we have clinical indices that indicate their lung function. So this is arterial oxygenation, arterial carbon dioxide, their pH, which is the acidity of the lung or the blood, and SpO2 is the saturation of hemoglobin. So how much blood is loaded into your hemoglobin. So these are the clinical indices that indicate these subjects' lung function before they've been on nasal high flow. And then we apply nasal high flow, and 1 hour after, we measure the same clinical indices again and to see if there is improvement. And what we want this model to do is we want our model to be able to represent these patients before the surgery, before the nasal high flow therapy. And then we want to predict, can our model predict the response of these patients 1 hour after the therapy? And then from that, we can tell, does the therapy work, and in which patients it works better, right? So one important advantage of this model is, before all our models are based on geometric models, we have to construct a patient's lung for every single subject based on CT, but that's not always available. What we want to do is use one generic model and see if we can use patient-based parameters like my height, my age, that I'm female, feeding into the model, and can this generalized model be parameterized to really represent every single patient within this patient cohort. So starting off with the general model framework, we use individual-based parameters to parameterize the model to represent each of those 20 patients. Was the first step. And then the second step, we apply each of those 3 mechanisms that might have worked for the standard therapy and impose it onto the model and see which one works and how the model predicts the response of these patients to this therapy. And what we find is, first, by using a generalized model geometry and these patient-specific parameters, we can tell that for those 4 clinical indices, so on the x-axis is what we measured clinically, and on the y-axis is what the model predicted of these patients before the therapy. And we can see there is an excellent correlation. It's almost exact correlation, a straight line between what the model predicts and what we actually clinically measure. And this really means that with one model, with just a general model and input parameters that's patient-specific, our model can represent the underlying disease, the clinical conditions of all of these 20 patients. So in essence, we have all of these 20 patients virtually in the computer. And then next, we investigate the first effect. if we begin the therapy and set your input oxygen to be exactly what it is during the nasal high flow therapy, how does these patients respond? And it actually says what our model predicts shows that here is one of the key clinical indices, which is your blood oxygenation. And here is axis of the input oxygen concentration that we used. The blue is what we recorded clinically 1 hour after the therapy. And the red is what our model is predicting with an increase in the input concentration, how the patient responded. And it actually shows that it matches really quite well, that with just only an increase in oxygen concentration, 60% of the patients have experienced reduced symptoms and improved oxygenation, exactly as recorded in the clinical recorded measures. And that really means that our model is able to reproduce and predict how these patients respond to varying amount of FiO2, which is the therapy. And then the second, but obviously there's another 40% that can't be predicted yet. So we want to next to see which other two of the effects, like what I said, is the reduction in dead space from the high flow and the possible recruitment of previously collapsed units. Does those work? Ooh. And we actually see, so what we did with the model is for all of these patients, we increasingly applied an increased amount of washout effect, so a stronger effect for all 20 of these patients. And then we use the model to predict what is happening, to predict how is the patients responding in terms of their arterial oxygenation and the carbon dioxide. And what we see is that there is a linear effect. If we apply more of the therapy, the patients behave better. But if you see the y-axis, the units like at the maximum is like 0.16, which is very, very small effect. So actually, it doesn't improve their clinical indices. But what it does do is it alleviates their symptoms. So what this is the work of breathing, which is a measurement of how hard you're working to be able to draw air in to breathe efficiently. So if you're short of breath, you're huffing, and you're breathing quick and shallow, and that means you're using a lot of effort. And that really places a lot of distress on you. So what this showed, the model predicts, is that with the increased amount of the therapy applied, you have less work, you're doing less work. So the models are really, this particular nasal washout therapy is able to alleviate you of the stress of breathing. It can help you breathe. Not necessarily change your actual blood indices, but it can help you breathe easier and more comfortably. And then next we move on to the last one, the last mechanism, which is actually saying that the mechanism can possibly recruit or open a part of your lung that was previously collapsed. And what the model shows is, so for the remaining 40% of the patients, which is actually 5 of them, the red is, what is this? Okay. So what it shows is that not only is a recruitment able to improve your blood oxygenation, but it's going to help you breathe. How does it help you breathe? So a tidal volume over here is how deep of your breath is. If you're expanding, breathing slowly, you're drawing more air in. Respiratory rate is the frequency in which you breathe at. So that kind of determines how efficiently or how hard you're trying to breathe. So if you're, for example, hypoventilating is short and shallow, and that takes a lot of effort. And if we're actually doing okay, then we breathe quite normally, slow and very deep. And what the model predicts is that for this particular alveolar recruitment mechanism, is able to increase the deepness of your breath and reduce the frequency in which you breathe at. So you're changing the respiratory pattern of those patients to be slower and deeper and less effort. And that's in addition to a significant improvement in oxygenation. So what our model is able to do is that using one generic model and a few simple, very easy to obtain parameters for each individual patients, we can predict the exact response of those whole 20 patients to different kinds of therapy. We know how much they're going to improve and exactly which mechanism is contributing to the improvement seen for these patients. So you can really see the benefits of this computational modeling framework in aiding the amount of therapy that the clinician can prescribe, because you know exactly which patients are going to respond to which kind of treatment. And so to conclude, what I've generally described is the model framework that we use in the lung group, where we start from individual patient-based data. We use the biophysically based equations to formulate models that describe the function of the lung and how we can apply this set of models and equations to aid understanding in diagnostics, therapeutics, and basically understanding the basic physiology, and really help in improvement of patient care. And well, as part of the MedTech CORE, my study is just a pilot study, and you can imagine in the future where we visualize we have only one model and very simple parameters that can be put in, and the model is able to predict every single response of the patient to one treatment. So you no longer require a trial and error approach where the clinicians test and sees which one works. You will know exactly beforehand how those patients are going to respond to a particular treatment, and we can apply it directly, and how that can really improve patient care and really reduce cost, hospital stay, and everything. Right? Yep. So this concludes my talk. Any questions? Questions? Are we good?
I wonder, how do you measure the pressure of various gas?
The pressure of various gas. The pressure is predicted here. So it comes from the model. The model is able to predict the pressure that's going through.
So no clinical data about it?
You can. So because it's a model, right? So you always want to know if your model prediction of pressure is correct. So what they have is various functional MRIs measurements, or sometimes you can insert like a catheter into the heart, right into the ventricle. Then you can measure the exact pressure in the heart, and you can match it with what your model predicts. Yeah?
What will be the age range that you can apply this model to? I'm wondering because, for example, in really small kids, the thorax is very flexible, and really old people, it becomes more stiffer. So it really changed within it.
Yeah, it really does. That's a really good question, actually. So for my study, this is actually based on normal age, so from I think 40 to a maximum of 80 years old. So it's really an elderly patient. But the same modeling approach works, but then you need to include the tissue properties or the individual or the size of the lung. This is why the size is important. By feeding in those information, you can capture the smaller kids as well, but you need to parameterize the model properly so you can capture those, because for small kids, it actually behaves slightly differently from or a grown adult or an elderly adult. And the additional complexity is if you have really, really young kids, like neonates, their lungs are not really developed yet, so it's actually more different. So really, in general, if you can clinically measure how they respond, then we will know when we can predict it. Yep, does that explain it? Yep.
And
Okay.
one last question.
Yeah.
You said that at some point you expand your model because I would think that the resolution of the CT scan doesn't allow to go into the alveoli detail because they are very small.
Yep.
So how did you?
So what it does is, how do I go back? So see, the resolution is not the best. So what we generally use the CT data is for tissue properties. That at that level we can capture, and the shape of the lung, and we can see from like these are the measure the bigger arteries and veins and airways, we can identify those. So these will be exactly patient-specific, and we use SYNGUI, where we manually map where the bigger vessels are. And then we use a complicated computer algorithm. It's called a growth algorithm, where we grow. So starting from this baseline, which is exactly based on CT, we grow the lung downwards towards the peripheries where we think the alveoli are located, and we make sure that expand the whole lung. And then afterwards, we compare to literatures, because there are literatures that can kind of evaluate how many alveoli are in the lung, what relationship does it have, usually how big they are. We compare our model predictions with what the literature say, and we see there's a match. So we can say, this is exactly how it looks like. So it wouldn't be exactly one-on-one match with each of the alveoli, but it will be a very good approximation. Yep. Is that all?